Hello, my name's Ian McCall, and this is another of the consultations in dermatology from the Australian Institute of Dermatology. Tonight I'm going to talk about, I've said, the black and pink spot, because I'm going to talk about melanoma. But before I do, I thought I'd read one of the consultations that Walter Shelley wrote about 40 to 50 years ago in his book Consultations in Dermatology. And let me just start with what he wrote. Because there's been a change, and it's important to see what attitudes were and what attitudes are now, what the opportunities are now to treat versus what the thoughts were then. Let me begin. He showed an image of a lady's elbow, and I've tried to simulate it with the case of my own that I've got here. And basically, he said this bluish-black mass on the left elbow of an 87-year-old woman had been slowly growing for the past 6 months. It had bled repeatedly, and the patient considered it to be a blood blister. There was no lymphadenopathy, no chest X-ray was normal. At the request of a family physician, the nodule was completely excised and proved to be a malignant melanoma. And Shelley goes on to say, this is black cancer, awesomely malignant. It can metastasize to every organ in the body, turn the patient completely black, and be fatal within months. Even after early complete surgical removal, cure is never absolute, but is measured only statistically in time quanta, for example, 5-year survival. Little wonder that the diagnosis is so dreaded when a lethal reappearance of the tumor may occur after a remission of 10 or more years. In view of the tremendous significance of this diagnosis, it's not one given lightly. Histopathologic findings should be studied under optimal conditions of fixation and staining, and review by one or more consultants is desirable, especially in lesions from youngsters in whom certain nevi may lead to errors. As clinicians, we can only be suspicious of all new or changing pigmented lesions in the skin, eye, or mucous membrane. The diagnosis is strictly a histological one, but black is the hallmark of the malignant melanoma, for it's a malignant overgrowth of the melanocyte, the melanin-forming cell. Many, possibly half, of the melanomas arise in moles or pigmented areas, hence our distrust of any mole which is changing or enlarging. The new pigmented spot or growth is equally suspect unless its benignity is obvious by virtue of history or study. But significantly, the black imprimatur may be absent at times, since melanin production is not essential to malignancy, but is rather only its common byproduct. In the unusual instance of the so-called amelanotic melanoma, there's no reduction in malignancy, and the patient's only hope is that his physician subjects all new and unexplained growths to histological study. Remember, the amelanotic melanoma may come in the clinical guise of a harmless fibroma. Now, Shelley goes on and discusses this tumor in some greater detail. But I want to point out a couple of things. You know, I've called this the black and the pink spot because the pink one refers to the amelanotic melanoma. I've said there that this is a tumor of melanocytes. And once the melanoma reaches a certain depth, it spreads via the local lymphatics and blood vessels. In other words, it has to be a certain thickness. It has to get down into the reticular dermis before it meets up with lymphatic and blood vessels, and then the cells will spread. If the lesion's thin, if the lesion is spreading out on the surface and not going down in depth, then it won't reach the lymphatics, it won't reach these blood vessels, and it won't spread. And that's an important thing, because the secret of curing melanoma is to get it while it's thin. And that's the big thing that we've done here in Australia, mainly due to the advent of good education and awareness of both the population and general practitioners in recognizing this tumor early on when it's thin. But also, there are some melanomas described as nodular melanomas, which grow rapidly and go deeply as well as rising above the surface. And when they hit that reticular dermis where the lymphatics of the blood vessels are, then the cells, the melanoma cells, can spread quickly. But the important thing that's been happening recently is that we now have some novel drug therapies which for the first time can slow and sometimes obliterate this disease. And we'll talk about these a little bit later. There's much more I can mention about melanoma, but I'm mainly going to make this pictorial, look at the various types to get your eye in, and talk a little bit about some of these new drug therapies that are available for this condition. So first of all, let's have a little look, I think, at the PowerPoint of this. It's always easier, I think, to present this in the PowerPoint. Okay, this was the picture that I put up to simulate what was happening with this patient of Shelley's. Now, this is quite an advanced melanoma. You've got this irregular edge here. You've got a large pigmented lesion that doesn't have anything similar around about it. It's an ugly duckling relative to everything else. This one is ulcerated as well. You can see the black pigment in the center here, and bits of that pigment bleeding out into the surrounding skin. Here's a much earlier melanoma. It still looks black, but you can see this one is thin. And you can see there are little areas possibly of regression here where the immune system has knocked off some of the melanoma cells. And this is something you've got to remember about melanoma. It is an antigenic tumor. It's a tumor that the immune system can react against. And we'll show you the ways in which it does it just in the morphology of some of these. But in this one, the tumor is growing out in the surface layers of the skin. It's not going deep. This is still a thin melanoma. Even though this is large in area, this is still a thin melanoma. That can be cured by putting margins of between 5 to 10 millimeters around the outside of this and cutting that out. This will not have reached the lymphatics or the blood vessels. This is just the dermatoscopy. Your doctor will probably have a look at this with a dermatoscope. And you can see, obviously, we can see the pigment patterns much better with the dermatoscope. And we can see how abnormal they are, how the network, the net-like network of melanin is changed and obliterated in these areas here. Here's another one on a lady's back. Now, sure, there are other moles, some of which aren't pigmented, but then you've got this one here. Let's get a close-up of it. You can see there's a small pinkish area just beside it, and then there's this pigmented area and this darkly pigmented area here. And if we look at that with a dermatoscope, this is the picture that you in fact see here. Melanocytes, when they're near the surface of the skin, they look very black. So when these cells that are usually at the dermoepidermal junction, which is between the epidermis and the dermis, when they start to grow up into the top layers of the skin and come up near the surface of the skin, you get this black color on the surface. Here, of course, is another type of melanoma. This is a nodular melanoma. Look at the difference. Look how elevated this is. Look at the black color of this. This one arose quickly. Within a period of 8 weeks, in fact. Whereas the ones that I showed you before on the lady's back, that was growing over a period of 2 to 3 years. So this one would go deep, and being 8 millimeters thick, it would certainly be down in amongst the blood vessels and lymphatics, and there's every likelihood it would have spread elsewhere. And this is the antithesis. This is another one on the back of an elderly lady's arm, sun damaged. You can see these other little keratoses, perhaps early basal cell skin cancers here. You can see the amount of freckling in the back of this lady's hand. And this had been growing again for 3 to 4 years. Initially thought just to be a freckle, but then you've got the varying colors, the varying types of pigment within this, the irregular edges. You know, it's like a stain on the skin. And this was still essentially inside you. It was all still at the dermoepidermal junction or above. It hadn't gone deep at all. This one, if you look at it, it's quite dark, but it looks nodular, it looks thickened as well, which it was. This was a thicker lesion, around 2 millimeters thick, So it certainly would reach the level of the lymphatics and the blood vessels deeper in the skin. And this is one that doesn't have much pigment on it at all. It appears to be exophytic. It's almost stuck on the skin here, but it's still a thick lesion. And this type of lesion can be mistaken for perhaps a squamous cell skin cancer or some other rapidly growing tumor on the surface of the skin. But it was in fact a nodular melanoma. Here's a common situation of a lady having a pigmented area on the face. Normally, freckles are of uniform pigment, they're the same color. Now, when you start to see one with varying levels of pigmentation like this and irregular edges, then you start to get suspicious. And in point of fact, this was what's called a lentigo maligna. It's really just another name for melanoma in situ, still melanoma at the level of the dermoepidermal junction. You'd be looking at that little area within it, though. It looks a little bit thickened there. You'd want to see just how thick that was when you did your biopsy. And you wouldn't do punch biopsies of this sort of lesion. It's a big lesion to try and cut out with narrow margins initially on its own. But what you can do is an incisional biopsy into that, where you're taking out any area that you think's a little bit thicker, and you're giving the pathologist a decent bit of the lesion to examine. This case had a little sting in the tail that we'll show you a little later. Here's another lentigo maligna melanoma, but this one grew over a long period of time, many, many years. And it was misdiagnosed earlier as just a solar lentigo. You can see the irregularity of it. You can see the variation in color. You get the impression that that's a little bit thicker there, as indeed it was, because this varied from a lentigo maligna, just in situ, just in the very top layers of the skin here, to an invasive melanoma here, and back out again to mainly in situ. This was cleared with a large skin graft, and the patient's very well. This was in fact a little biopsy, several biopsies. I mean, obviously you can't even take a big incisional biopsy in that case. And in fact, a whole series of biopsies were taken across it to get an idea of the thickness. And you can see here how the skin, the pigmentation is confined to the top layers of the skin, here extending into the reticular dermis at this level. This is fat down here. And this is the histology of one of the thinner areas of that particular lesion, where the abnormal cells are these ones along here at the dermoepidermal junction and going down the hair follicles. This is what a melanoma in situ will in fact, or a lentigo maligna melanoma will look like. It'll be basically in situ going along the dermoepidermal junction like this. These are some pigment cells that have fallen out of here because of any immune attack, and they're taken up by macrophages. This is just pigment. It's not active melanoma cells. Here's a patient who's got two sorts of lesions on the nose. This one looks as if it's a very thin lentigo maligna-like melanoma, but this is much darker, much deeper. Difficult to say whether it's elevated or not. And if you look at these two with the dermatoscope, then this is what they look like. Just because that's black doesn't mean to say that it's thick, but this in fact was an invasive melanoma. This was all in situ. It was all just above the dermoepidermal junction. Here's a situation we often see in the elderly, where there's a variety of pigmented lesions in the back. Many of them are just simple seborrheic keratoses, which are benign pigmented growths, but not melanocytic growths that occur in the skin of the elderly. But often you get these varying pigmented lesions. They're not rough, they're in fact smooth. And these are known as lentiginous melanomas. Again, basically melanomas in situ, just in the top layers of the skin, dermoepidermal junction and above, not going down into the area where the blood vessels and lymphatics are. So these can grow to quite some size, without really posing any great risk to the patient. But over time, a little clone of cells may develop that are more aggressive, and the lesion will thicken in these areas, and it will go deep. It will penetrate through the dermoepidermal junction and go into the dermis and invade down in blood vessels. So these should still be treated and not just allowed to get bigger and bigger. There's the more typical melanoma that you may see, the variation in color, the irregular sharp edges. And if you put a dermatoscope on this, there are a variety of dermatoscopic features here that are compatible with melanoma. Pseudopods, lines radial peripheral, blue-gray structures here, varying colors of pink, dot vessels within the pink areas. Again, some pseudopods out here, and some dots that are peripheral clods of melanocytes, indicating proliferating nests of cells at the periphery of this lesion. But this is another melanoma. This is the pink. We've talked about the black, but this is the pink. This is an amelanotic melanoma, raised, thickened, ulcerated here in the center. May look like a basal cell skin cancer. It can be awfully difficult to pick these clinically. The dermatoscope can help, but again, you've just got to be aware of any new elevated pink and growing lesion, EFG, elevated pink and elevated firm and growing lesion on the back, especially in males, should be taken seriously as perhaps being an amelanotic melanoma. And these have to be excised to be diagnosed properly. This is one from one of my colleagues, Ben Cook, and you can see the pink lesion in the outer aspect of the arm. This is the clinical view. There's no pigment to see in this at all, but it was rapidly growing, firm pink nodule. And this is the dermatoscopic view, where there's polymorphic vessels, but only a few dot vessels this time. By polymorphic, we mean there are different patterns of vessel growth here. And sometimes this is all you have got to go on in trying to diagnose these. But basically, any undiagnosed, growing, nodular, firm, pink lesion like this has to be excised and examined. Here's another one, not so much raised, this one, but again, just a pink area on the back. And the situation here is that it can be very difficult to diagnose this. You may think it's a basal cell skin cancer. And if you try some ablative measures on that without sending specimens for pathology, you'll never know. Again, this is the dermatoscopic image with some of the dot vessels that you see in this. And if we enlarge that and look closely, you'll see that there's other linear vessels and some coiled vessels there as well. Sometimes, unfortunately, the pathologists get it wrong the first time that a pigmented lesion is excised. And this is a case where a lesion was excised here before. This is the scar line you're seeing, diagnosed as a dysplastic nevus. But in point of fact, the patient then, for one reason or another, wasn't followed up, and about 4 years later they returned, and this is what had happened. The lesion had recurred around the excision site here. So the initial diagnosis was wrong. Sometimes you can get melanomas occurring in unusual areas, and this is one where it's difficult to fathom what's been going on. This is the scalp, and this was only picked up by a lady who was cutting her husband's hair. The mole before had all been like this. It had all been this color, just a nice pink dermal type nevus that you get in the scalp. But then half of it had started to form like this, and you had a 2.6 millimeter thick melanoma developing in association with this. Now remember, the other thing that's important about melanoma, you know, Shelley sort of said half melanomas may arise from pre-existing moles. At his time, that indicated that half arose de novo. We now think that possibly 80% of melanomas actually arise as new lesions. They are not evolving from a pre-existing mole. They're coming as new lesions, and that's an important thing. Some people think if they have all their moles excised or all their unusual moles excised, that this somehow lessens their risk of developing melanoma, and it doesn't. There's another unusual type of melanoma, acrolentiginous type. And this is one that's occurring on the palms of the hand or the soles of the feet. And it may present as just as a dusky pigmentation change like this. Dermatoscopes help here. There's a particular pattern called the parallel ridge pattern. You can almost see it here when you look with the dermatoscope. Most of the pigment is in the ridges. The furrows are these narrow lines here. The ridges are the thick ones. And if you get in close to it, you'll see that most of the pigment's in the actual ridges. So it's a parallel ridge pattern for an acrolentiginous melanoma like this. These can be misdiagnosed because you don't expect to get something on the sole of the foot or between the toes like this. We tend to think that most melanomas are associated with patients having excess sunburns when they were younger, and certainly that's a major factor. But a lot of melanomas can arise where there's been no history, in fact, of sunburning or even excess sun exposure before. And that's the unfortunate thing about this condition. Here's another one in the ear. And this shows this pink area here. This is where there's been some regression. This is where the immune system has attacked this melanoma, and it's knocking bits of it off. And so you've got a pink area here, a little bit of pigmentation here. So it indicates that the immune system plays a big part in getting rid of melanoma. And we've got to be careful with anything that we do that may interfere with the actions of that immune system. And I'll discuss that further when we talk a little bit about a thing called sentinel lymph node biopsy and removal of lymph nodes. Here's another area where you might not expect to see a melanoma, in the hair-bearing area of the scalp. And, a patient wouldn't recognize this. Their barber might well recognize it. Note the variation in the pigmentation here. Note the size of this. This is thin, though. It's not a thick melanoma. This, in fact, was all in situ. It hadn't got any depth to it. It wasn't going to spread anywhere at all. It was continuing to grow out on the surface like this. And here's another unusual type of melanoma, a subungual melanoma. It's occurring under the nail. You develop a black line. Sometimes that black line extends into the cuticle of the nail here, called Hutchison's sign. And here you can see the pigments extending now out into the skin on the front of the toe as well. But the melanoma is actually back here in the nail matrix underneath the posterior nail fold here. And it's incorporating melanin into the actual nail itself. If we looked with a dermatoscope here, you'd see lines of varying width and varying color involved in this. Of course, the other lesion that can occur here is a subungual hematoma, where you've injured your toe. And that looks very different under a dermatoscope, with globules of blood, not with a whole series of lines like this. And you don't get that sort of spread onto the surrounding skin, either if it's a subungual hematoma. These are often thicker before they're actually diagnosed. Thickness is something I haven't really talked about, but the vast majority of melanomas that we see nowadays in Australia are either in situ or less than 0.75 of a millimeter. And melanomas that are less than 0.75 of a millimeter thick, if you get these cut out, then your 10-year survival rate is up there in the high 90s. So those are very, very good figures. What you don't want to do is to get one that's going to be more than 3.5 millimeters thick, because your survival rates drop then, 10-year survival rates drop roughly to around 30 to 40%, because these lesions may well have spread elsewhere. And this is just another example of one that spread very slowly. This is all melanoma up here, all of it, all the way out here. This had grown over a 4.5-year period. And, you can see where some of the cells are now nearer to the surface and they become black like this. And again, when this was in fact formally excised, it was all still in situ. It had not gone through into the dermis or got anywhere near blood vessels, so there was no risk to the patient. And an excision and graft here was all that was necessary to cure this problem. Unfortunately, you can get melanomas like this. I've got another picture with a patient with their eye closed here, and you can't even see this. It's only when the lid's elevated that here's a melanoma occurring within the choroidal pigment in the eye. Because remember, melanocytes are not just in the skin. There are some in the back of the eye, there are some in the brain, there are actually some in the gut as well, and a small proportion of melanomas can arise primarily in those areas. But they're rare. You can also get melanoma arising in mucosal areas, the inside of the mouth and the genital areas. And often these are misdiagnosed here. They're not diagnosed for what they are, so they're often thicker before they're in fact diagnosed. And occasionally you can get melanoma developing in a patient like this. Again, that's almost an amelanotic one with and this, what you're seeing here, is where a biopsy was in fact done because it wasn't recognized that this was in fact a melanoma. And in this case, the thickest portion of the melanoma was about 1.3 millimeters thick. So it's a thicker lesion. The cells, there's no maturation of these cells in depth. Often they have a spreading edge with a bit of infiltration down here into the deeper layers of the dermis, and there were a lot of mitoses, which is a measure of the overall activity. Mitosis just means the rate at, it's an indication of the rate at which these cells are in fact growing. And the more mitoses we see nowadays, the more worrying a particular lesion is. Sometimes when you have a thicker melanoma, one more than 1 millimeter in thickness on your limbs, arms and legs or on the trunk, your surgeon may suggest a sentinel lymph node biopsy. And the idea here is to see if there's any evidence that the tumor has spread to the local draining lymph nodes. Now generally, it's only tumors that are a millimeter in thickness or more that are likely to do this. Much thinner melanomas are very unlikely to do this, and there's very little point in doing sentinel lymph node biopsies. It's sometimes done if you've got one between 0.75 and 1 millimeter that's also showing mitoses. Then because of that mitoses, the increased number of mitoses, it's sometimes advised then as well. But I'm not going to go into the ins and outs of how they do this, but the sentinel lymph node is the one that's the first one in a chain that's most likely to have any draining abnormal cells in it. And they can localize this by using a blue dye or by using a radioactive isotope. And the surgeon goes in and cuts this particular node out, and this is then histologically examined to see if there's any signs of melanoma there. Now what it's found, or what's been found, is that patients who have negative, if a patient has no evidence of any melanoma cells there, then in general they will live, or that group of patients I should say, will live longer than a group of patients with a similarly thick melanoma who do have some cells in this sentinel lymph node. It doesn't change the prognosis for that one individual. It just tells you which group that you're going to be in. I don't know if you want to know that. It's not going to change what's going to happen to you. And even within that group, there'll be some patients who will live less than the mean and some that will live longer than the mean. And that, it doesn't tell you. It doesn't tell you what's going to happen to you as an individual. It just tells you that you are part of a group who either have who are more likely to live longer or who are likely to live shorter. So because of this, because it doesn't tell what's going to happen to you specifically, many people question whether this knowledge is worth the extra surgery and the possible morbidity of a swollen limb, because when you take out some lymph nodes there, it may interfere with lymphatic drainage in the area, and you may get a swollen arm or a swollen leg afterwards, and that can be quite an imposition. It's not often that that happens, but it can. The time when it may happen is that if your sentinel lymph node's positive, and the surgeon then says to you, well, we want to cut out the rest of your lymph nodes to see if there's any tumor there. And if there was, then you'll be better off because we have this out, and it therefore won't sort of recur in this area later on. Now the problem is that taking out those lymph nodes isn't, whether there's tumor there or not, isn't going to change your long-term life expectancy. That's been shown for years. That taking those out, whether there's tumor there or not, doesn't change your lifetime risk of dying, when you're going to die. That's because melanoma spread not only via lymphatics, but also through blood vessels. And if they've gone to lymphatics, they may well have gone into the bloodstream and spread elsewhere. And certainly if you have all your lymph nodes taken out in your axilla or in your groin, then there's every likelihood that you're going to get chronic lymphedema, a swollen edematous limb afterwards. And it's something you really have to weigh up, whether you feel that should be done when it's not going to change how long you're going to live, versus if the tumor does progress further there, and not all do. Remember, these are lymph nodes. These are lymph nodes that are meant to induce an immune reaction. They're meant to trap antigens and infection and what have you, and get your immune system to react to it. So these lymph nodes are there for a purpose. Now, sometimes the melanoma is growing so rapidly that it just obliterates the lymph node. But there are other circumstances where the tumor is held there. It doesn't, in fact, multiply. It doesn't, in fact, give a fungating mass. And we still really don't know whether it's better to leave things there or not. We don't know whether the immune system is being a beneficial thing here and holding things in control, or whether it isn't. And there are studies on the go just now to try and ascertain whether, if you've got a positive sentinel lymph node, there's any benefit in going ahead and having the lymph nodes removed, or in fact in leaving them there, in terms of your immune reaction to tumor. Here's another melanoma, one that doesn't look like one. It's pinkish, and this is nodular. You can see it's raised. And this was an invasive melanoma. But the patient, it was 2 millimeters or more in thickness. The patient had negative sentinel lymph nodes when he was examined. Unfortunately, this is what can happen with melanoma as well. This is a skin graft where the patient had a 2.6 millimeter thick melanoma removed, but in point of fact there was still residual melanoma left in lymphatics, and it recurred within the actual skin graft itself. And this is melanoma that's recurred locally within a grafted area. And unfortunately, when melanoma gets into the bloodstream, it may metastasize, and these tumors change all the time. The one that's here, if you analyze it, isn't the same tumor as the one that was there, the very original one, because the amount of division that and cell proliferation that's occurring, there's a whole lot of genetic changes occurring in these as well. And that's why vaccines haven't worked, because you're trying to make a vaccine to your original tumor, but the metastases are different. They're different from the original tumor. And so vaccines for the treatment of melanoma haven't really been successful at all. When you get systemic spread like this, and it comes up like this in the scalp, because the scalp has very good blood flow, and so cells tend to lodge there. When it comes up like this in the past, there really was nothing that could be done for patients with this type of melanoma spread at all, until recently. And this is where things are very different now, I think, from in Shelley's day. Because nowadays we have drugs that are called BRAF inhibitors. The BRAF gene is one that's seen in I think about 60 to 70% of some melanomas. And these particular genes are involved in regulating cell metabolism. And when these genes have mutated, then the controlling aspects of cellular metabolism are lost, and cells, in a whole variety of tumors, not just in melanoma, but in colon cancer and other cancers, BRAF inhibition, in fact, occurs. And the drugs that have been developed recently inhibit these BRAF mutations. In other words, they slow down the rate at which cells are turning over, at which new cells are being created. And some patients who have been, usually they've been patients who have had metastatic disease, like that last man I showed you. Some of these patients have shown remarkable improvements when they've been given these particular drugs, which will stop their unregulated growth. There's a variety of companies working with a series of these drugs, but it takes a little while to find what side effects may occur with them, and ones that have occurred in patients who have been given these particular BRAF mutation inhibitor drugs has been that they've been developing squamous cell skin cancers. Now, they've not been particularly aggressive squamous cell skin cancers, I understand, but they've still been developing other types of skin cancers. So it's a curious thing. The only other drugs that had been available in the past was one called dacarbazine, which was an alkylating agent. In other words, it introduced a molecule to the DNA of the melanoma that damaged the DNA and stopped the melanoma developing. But they were not terribly effective or terribly specific for the melanoma cells, and they gave a few extra months of life when they were given. But there was no way that they could be considered curative in the same way that some of the BRAF inhibitor drugs have appeared to act. Another therapy that can be used is a topical therapy for skin metastases. And this is a compound called diphenyl cyclopropanone. It's actually used in treating warts. It's a chemical that we seldom come in contact with, if ever, but it's highly allergenic. You can put 2% concentration on the inside of someone's arm and make them highly allergic to it. And then you paint a lesser concentration on the melanoma itself, and it really attracts in a whole lot of lymphocytes into that melanoma. And these lymphocytes, as a byproduct, seem to knock out the melanoma cells. So for skin metastases, this therapy has proven quite useful, and it just reflects the importance of the immune system in trying to treat these lesions. Obviously, though, if you've got a metastasis internally in the brain, heart, other parts of the body, then you can't reach it with this particular preparation. But one of the thoughts might have been that, if you can induce some form of immune reaction in lesions in the surface of the skin, that the immune system will still seek out perhaps metastases elsewhere and mount an immune reaction on that as well. Not enough patients have been tested yet with this type of preparation to see if that is in fact the case. But the important thing nowadays is that there's hope out there for people who have thick melanomas. The important thing, though, is to get the melanoma when it's thin, so that the message has to be, if you've got a new pigmented or non-pigmented lesion, for that matter, that's changing, that looks different to anything else that you have in your skin, or you've had a mole, I should say, that's changing, or a new pigmented lesion, then you have to go and get it looked at by your doctor, and get in early and get it looked at. Your doctor will probably examine it with a dermatoscope. If it's a simple thing like a seborrheic keratosis or the like, he'll reassure you. If he or she feels that this is a significant pigmented lesion with features that dermatoscopically suggest melanoma, then they'll advise initially excision with narrow margins. Try not to use punch biopsies of smaller pigmented lesions. The lesion is going to be examined. It should be examined intact. It should be taken out with narrow margins initially so that the pathologist can see it properly. If you just do punch biopsies of things, then it may not be representative of the histology there. The wrong diagnosis can be made. So an excision biopsy or if it's a large lesion, large pigmented area in the face, then an incisional or sometimes even a shave biopsy gives the pathologist a reasonable specimen to make their diagnosis on. And thereafter, a re-excision will be done depending on the thickness of the melanoma. That's the standard practice for dealing with suspicious pigmented lesions in Australia at this time. There are things called melanoma guidelines that have been put out. I think the latest were about 2 years ago. I might end by just having a look at a thing that's available called a risk calculator. And let me bring up this one. This comes from the Royal Marsden Hospital. It's www.melanomaprognosis.co.uk. And if you go there, you can put in, you just have to fill in a couple of little details that they ask for. And this can calculate very quickly, taking into account whether you have sentinel nodes done or not, whether there's any involvement or not, what the thickness of the lesion was. Serum LDH is an enzyme that is sometimes done with thick melanomas, seldom with thin ones. And what this can do is it can give you an excellent estimate of the average life expectancy of people who have those whose melanoma has these characteristics. Now remember, it's an average of everyone, but averages don't apply to individuals. Individuals may be below the average or above the average, but it just gives you an average idea. And the thing is, though, that the expectancy, I'll put one in here, where there were no metastases, where no surgery was required, where this was a thin lesion, less than 1 millimeter in thickness, with no ulceration or mitoses in the microscopy. And when you looked at that, the average life expectancy was 99% average chance at 2.5 years, 97% will be alive at 5 years, and 93% of people with melanomas with those features will be alive at 10 years. So these are good statistics. Remember that for thin melanomas. The whole idea is to get your melanoma when it's thin. So if you've got an ugly duckling lesion, one that is new, a mole that has changed, a new pigmented, a new pink lesion that's perhaps growing on your skin, anything that's bleeding unusually, then go to your doctor and get it examined, and make sure that you're going to be in the group that has, if you're going to have a melanoma, that it's going to be a thin one, less than 1 millimeter in thickness, which has an excellent long-term life expectancy. I've started off with Shelley's comments, which 40 to 50 years ago were really quite despondent, because in those days many people didn't present until later on, when the melanoma was invasive. Nowadays, most people present when these lesions are thin. Most doctors, when they're examining you for something else, they'll be checking your skin, scanning it to see if you've got anything there that catches their eye. In Australia, we're very well aware of this tumor. And when your doctor examines you, he'll check around your hair margins, he'll check between your toes. And if you're a lady with any pigmented lesions in vulva or the like, then you should visit a lady doctor and have those areas examined as well. So the important thing is to see your doctor early, and the prognosis is in fact very good when melanomas are taken out when they're thin. So I hope I've got that message across in this talk tonight. Thank you very much.